Good afternoon. This is Dr. Aaron Shiloh speaking to you today about peripheral arterial disease, and I'll also be briefly mentioning something about vein diseases. Some patients who have skin breakdown and ulcers in their legs have a combination of both diseases, so it's worthwhile discussing both. You can't see me, and there's an issue with the camera at the moment, but you can see here, this is what I look like. So anyway, let's talk a little bit about PAD. What is peripheral arterial disease? Here we go. So this is a little bit about me. I'm an interventional radiologist. I practice in the Philadelphia area. I've been working in the Philadelphia area for pretty much my entire career. After training here in Penn State and then attending the University of Pennsylvania, I've stayed in the Philadelphia area and spent the vast majority of my career practicing as an interventional radiologist in multiple community hospitals, some of which have been affiliated with some teaching hospitals as well. But now for the last 6 months to a year, I've been working at USA Vein, Fibroid, and Vascular Centers. So let's talk a little bit about what is PAD. PAD stands for Peripheral Arterial Disease. PAD affects a lot of people, almost 20 million Americans. A lot of people think about arterial disease in the heart, and this is its cousin. It's very similar, but except it's not in the heart, it's in the lower extremities primarily. So there's an estimation that approximately 200,000 people suffer avoidable amputations every year, and that's really tragic. These amputations are typically caused by infections and the poor wound healing, and the poor wound healing is secondary to blocked or reduced blood flow to the legs. Otherwise, you can have additional symptoms that we'll discuss momentarily. So in the setting of peripheral arterial disease, you can see this is kind of what happens to the artery as you look across the screen. So in image number one shows a healthy artery. It's basically a nice hollow tube with a muscular wall. In number two, you can see that there's development of this plaque, as you can see at around 12 o'clock position, and that's mild atherosclerotic changes. Then as you look at the number three, you can start to see some more significant buildup of atherosclerotic change with multiple lipid core layers and this fibroatheroma, which is kind of a technical term. And then finally, you can see that in the picture number four, there's a fairly significant plaque buildup, and you can kind of see what the problem is. There's very little lumen. There's almost no passageway for the blood to get through, which causes a problem. And then sometimes that artery can just completely close off when there's not enough blood flow. So within PAD, there's often some people make a differentiation between arteriosclerosis and atherosclerosis. They're very similar to each other, but arteriosclerosis is a hardening of the arteries. Most healthy arteries are flexible and elastic, but too much pressure in the arteries can make the walls thick and stiff, and that can create issues. Atherosclerosis is the buildup of fats and cholesterol in and on the artery walls, like we saw in the previous slide, which then leads to limitation of blood flow. Sometimes these plaques can rupture, and when they rupture, the body's says something's wrong here, and the clotting mechanism goes to that location. And in fact, when the plaque ruptures, our body will react to that, and it will cause the entire artery to clot. This is a very significant and more acute problem. And again, it's almost the cousin of the same disease that occurs in the coronary arteries, which is in the heart. So why is PAD a growing problem? Well, it's one of the most prevalent, morbid, and mortal cardiovascular diseases. Most people are unaware of it as an issue. Obviously, a lot of people know about heart disease. It's really obviously discussed a lot, and certainly the heart is very critical. But this disease is as prevalent, if not more so, and it's often underdiagnosed and undertreated because of a lack of recognition of both patients and sometimes, unfortunately, also clinicians. PAD risk is actually highest in African American and Black population, and that may also talk to a little bit of the differential in care. And so we certainly strive to try to educate people and to try to treat as many people with this problem as possible. So who's at risk for peripheral arterial disease? Well, patients over 70 years of age, but really, if you're over 70 and healthy, you're less likely to have this problem. You can be much younger and have issues like diabetes, high blood pressure, high cholesterol, and smoking, things you hear about a lot as it relates to heart disease. But the same disease, as I mentioned earlier, can affect the arteries of the lower extremities, and these are the most common risk factors. So patients who experience foot, calf, buttock, or hip pain while walking that is relieved by rest are those who we consider to have some degree of peripheral arterial disease. It's actually a term called intermittent claudication, and hopefully we'll get a chance to talk about that shortly. There's also people who experience pain at rest. That's actually a very severe form of peripheral arterial disease. If you're really not moving and you're experiencing pain in your legs, particularly when you're laying flat, that's considered to be rest pain and is fairly diagnostic of fairly severe disease. So, what does some of the peripheral arterial disease look like? Well, people whose toes or feet are pale or discolored or blue. A lot of times the feet may actually feel cooler, or one foot may feel cooler than the other. You can also see is basically a delayed amount of blood return. So, for example, if you squeeze your toe and it takes an awful long time for it to turn, red again after you blanch it, then that's an issue. That just shows that it's taking a little bit of time for the blood to return. Obviously, skin wounds or ulcers are an issue, and that is often manifested by not having good pulses in your feet. So finally, without good blood flow, you're highly predisposed to developing an infection, and many diabetics know this, that it's certainly a risk for them when they get an ulcer in their foot or wound, that it won't heal properly, and many times that's related to insufficient or poor blood flow to allow for effective healing. So as I just mentioned, in diabetes, it causes what's called a small vessel disease. So really, we see diabetes affecting the arteries below the knee. I'll show a picture of that shortly. The International Diabetes Federation estimates that every 20 seconds a leg is lost to diabetes. That's really horrible. And only about 49%, or half of patients, had any real vascular evaluation prior to their amputation. So each year, there's about 80 to 90,000 diabetes-related lower extremity amputations, which cost an enormous amount of money to society. So comprehensive foot care programs can reduce amputation rates by up to 85%. So as I was mentioning, what are the common symptoms? So pain or aching in the legs, but it's more than just pain or aching. Most commonly, it's a cramping that occurs in the calf muscles when someone walks. And a lot of times they can say, well, I can walk a block or two, then I develop pain in my calves, and I stop and the pain goes away, and then I can start again and walk another block or two. And that's a very common complaint and is associated with intermittent claudication. Other things such as hair loss, numbness, and as I mentioned earlier, poor wound healing in those people who develop them. Now, some patients with peripheral arterial disease can in fact be asymptomatic and may not show any symptoms. Sometimes it's because they don't really exercise too much, meaning they don't go for walks, and thus it's hard for them to tell that my leg is really a problem. Sometimes people will, walk through the pain, and which is a good thing, in fact, and then collateralize or form new blood vessels around the blockage, which can also help them as well. So there are estimates that say that approximately 50% of PAD patients are asymptomatic and can be very difficult to diagnose. Large vessel peripheral arterial disease increases significantly with age. It's certainly more common in men than women, and a large group of patients with PAD have evidence of coronary artery disease or other heart diseases. So I'm just going to show a few cases which can kind of highlight what the problems are. I think that in our image-based society, most people can kind of tell the difference in these before and after photos. So in this picture here, this is an 85-year-old gentleman who I treated, who's still doing really well. It's actually probably about, I don't even know, 5 to 10 years ago now. He'd actually had 2 prior attempts to fix this. And what we can see here is that there is a blockage that is occurring right here. So this is an artery in the thigh. You can see these little bumps. Those are all calcific plaques. And then here, there's a giant gap where there should be an artery. And what the patient developed was all these large collaterals, so these extra vessels that essentially bypassed this problem. But you can imagine that as the blood is flowing down here and it's trying to get down this superhighway, it's running into this obstruction. Now it's got to get around and around and around. It's sort of like a massive traffic jam on a highway where people start taking the side roads and try to get around, it clearly moves much more slowly. So then we look over here to the other side of the screen, and you can see that after placement of a couple stents and with some extensive work from both above the knee and below, I was able to reconstruct and recreate the artery to supply his foot. And you can imagine the dramatic difference the person feels when they have no blood flow here and this thing is, buzzing along. So it really is a dramatic improvement. And I know he was thrilled, and I'm sure he's still thrilled now that he continues to do well and can lead his life. Here's another example. This is a 50-year-old diabetic truck driver who had severe rest pain in both his legs and also in his butt. And that's because this picture here in the upper corner is an image actually of the artery in the abdomen and pelvis. You could see there should be two of these, one going down the one leg and the other going down the other leg. So this is the right leg. This is if the person is laying on the table and you're standing above them. You can see this is really irregular. And over here, there was no blood flow at all. There's no artery here. It's gone. So with some extensive work, we're able to get up through this blockage and then into the aorta itself. And then again, after some extensive work, we're able to put in two stents, one on the left side, one on the right. It's actually got a interesting term called kissing stents because the stents essentially seem like they're kissing each other, and it recreates this aortic bifurcation. And he did amazingly well and was very happy with the fact that his pain was resolved, his buttock pain was resolved, and he was able to really walk again in a much better way. Finally, as an example, here's another picture of a 70-year-old diabetic with a non-healing foot ulcer who was about to undergo amputation. And again, you can see this here is, again, that artery in the thigh. I mean, if you look closely, this is the femur, this is the bone of the thigh, and it's a very common location for problems. Right when the artery crosses over the bone here, there's a little canal there, Hunter's Canal, or and it can create a real issue here. So you see how narrow this is here. In addition, below the knee, there are supposed to be large blood vessels here that feed the foot, and none of these are normal vessels. They're all basically out. This here, where my arrow is, may be the normal vessel. This is a squiggly line. These are not normal. None of these are actually normal. So what did we do? We reopened this area here across the thigh, and that's demonstrated here. You can see that was then opened, and you see there's a massive difference between the appearance of the artery here and the artery on this side. And then subsequently, we also were able to reopen some of the arteries to the foot and create an inline channel here, which we can see there very nicely. And this person was able to heal their foot ulcer and actually not have to undergo an amputation. All, of course, very rewarding for the patient and very satisfying for us as well, to be able to help someone avoid that type of issue. So I would like to say that, if left untreated, peripheral arterial disease can lead to multiple problems. Of course, loss of mobility. People are unable to go for walks, and that affects their health globally. Certainly, it's a shame, but people are still getting amputations in this country despite not having vascular workups beforehand, which is really something that we would like to see stop. I mean, it's not, sometimes amputations are necessary, but some patients really can avoid it if they get in the right person's hands and they can really make the proper assessment and identify the problem and treat it properly, and not just say, hey, let's just cut this limb off. Finally, as we mentioned earlier, PAD is the cousin of other diseases like heart attacks or stroke, because a disease that affects the arteries to the legs almost always affects other arteries in the body to some degree. And so to be evaluated for PAD and or to get that diagnosis of PAD, at least it identifies another potential problem either in someone's heart or in the arteries to the brain. And so we've been doing lately a lot of testing called ABIs, which are an ankle brachial index, where we try to measure in a very non-invasive way the difference between the blood pressure in someone's arm versus their leg. And if there's a pressure difference, that indicates that there is some type of a blockage in their lower extremity. So it's another very useful tool that we use here at USA Vascular Centers to assess patients' circulation and specifically their arterial blood flow. So if we can detect this problem early, we can restore your mobility. We can also hopefully reduce the risk of other significant vascular complications, including stroke, heart attack, amputations, things like that. So if anyone wants more information about this disease, there are many ways to reach me and to reach any of my colleagues at USA Vascular Centers. We have obviously an 800 number, which is here on the screen. You can go to usavascularcenters.com. There's also a PAD toolkit that can be downloaded. And we really believe very strongly that these diseases should be identified and, when appropriate, should be treated before there are significant issues or complications. Okay, I guess, maybe that wasn't the longest. If anyone has any questions, I'd be happy to answer them, whether they're verbally or see if there's any questions. So far, no questions. Yeah, I mean, I'll wait here for a few minutes. If any questions anyone has, I'd be happy to answer them directly. If you don't feel comfortable answering or asking your question, I can be also personally reached at Shiloh at usaveinclinics.com and be happy to answer any questions. I guess I'll ask myself a question since these things come up. I mean, are these things covered by insurance? Yes, all this evaluation and subsequent treatment is covered by insurance. The other question is, well, what are the treatments and how are they done? Where are they done? Well, amazingly enough, through the advances in medicine by doctors, a lot of them in my particular field, interventional radiology, we've made it so that these treatments are very simple and straightforward, and they can be done in an office rather than a hospital, which obviously in this COVID era is a big deal. If you can get something done without going to the hospital, I think it's extremely beneficial. The procedures are all minimally invasive. They're either done through an artery in the groin, sometimes the artery in the foot, and very rarely the artery in the wrist. But basically, it's done all under ultrasound guidance to get access to the artery. And then using a combination of X-ray, ultrasound, and other tools, we identify the areas that need to be treated. And then we treat them with a combination of treatments such as atherectomy, which is to remove or burrow out a hole or channel where there's a very dense plaque. There's balloon angioplasty, which is what it sounds like. You take a balloon and you gently inflate it, and what it does is it cracks the plaque that's up against the wall and then creates a larger lumen. And then sometimes, if that angioplasty alone is not sufficient, then we have to place an internal scaffolding, which is otherwise known as a stent. So the combination of those treatments also is used at times, and all that, again, as I said, is done in a minimally invasive way in our office with a little bit of light sedation, and patients come in, and a couple hours later they can leave on their own. And so this doesn't involve a hospital stay, and it's all done by our expert physicians in our many locations all over the United States. And again, I'm personally here in the Philadelphia area, and I'd be happy to help anyone who needs my help. So again, if there's no further questions, I appreciate everyone's time, and hopefully you've learned something today, and you or your family member can benefit from this in some way. So thank you very much, and have a great day.